Ravindranath now, who will be speaking on the day-to-day problems of the OPD communication. See, we normally, patients first come to OPD and then see us, then they decide whether they should come into the OT or not. So OPD is something where most communication happens, and that is where we can actually goof it up, and we can also actually win brownie points. So that's where the broadcast area is most active. So we have none other than Dr. Ravindranath, who is a practitioner in Davangere, Karnataka, who has been very successful with his broadcast area. So over to him.
Thank you, KP, for keeping me in the squad, even after inconsistent performances. This topic is very close to my heart because this is the one thing which I have not learned by reading books. This is totally experience for the past 25 years, and intelligence can be artificial, but stupidity is always natural. So this all things have I have learned with my stupidity. The situations are many situations when you communicate with it could be with the patient or attendant or staff of the hospital, colleagues. Sometimes VIPs. There are two types of VIPs. One are real VIPs. Second, the people who think they are VIPs. The second type of people are very difficult to manage. And some people come with colorful visiting cards and claim that they are head of secretary of some organizations. Those are the difficult people to convince and communicate. And government officers. Many a times these officers come with a title. You know, when they come, they don't come not only as patients, they come as commissioner, they come as police officer. So they think they are officers even in our offices. And some special situations where you have to break the bad news and talk to the mob. And you are head of the hospital, and you are responsible for the communication of your staff, counselors, nurses, other doctors, case sheets, consent forms, instructions, and handouts on displays. So basically you have to take in charge of all these because you are responsible for this. So communication can be verbal, writing, signs, or even act, body language, attitude, and tone. So all these constitute the communication. So any communication mishaps, because of these things you are responsible, and you should change. So the areas in the hospital where you can have these interactions is reception, waiting hall, consultation rooms, procedure rooms, inpatients, OT, and post-op events. So as my talk is with respect to OPD, I'll just say, first, when your patient comes, he'll go to registration. The two important areas, important things where at the time of registration, miscommunication can happen. That is, one is waiting time. See, many of the times, our reception will tell, wait for a few minutes and wait for some time. The some time and few minutes are subjective. Few minutes can be 5 minutes for you, for the patient, it can be 2 minutes or 30 minutes. So you have to be very specific and instruct the reception area that what is the approximate expectation of waiting time. It could be half an hour, give a range, 30 to 45 minutes, 1 to 2 hours, and it will solve most of the problem. If you say, wait for some time, wait for a few minutes, things are not done. So this is one area where communication gap can be there. Second is triage. See, you have to triage the patients because some patient with diabetic retinopathy needs dilatation, OCT, scans, maybe lasers. They may need even 2 hours, 3 hours. But if a patient comes with a conjunctivitis or external hordeolum, it takes only 2 to 3 minutes. So basically in waiting area, the reception should bifurcate the patients who need immediate and early treatment, and you can be disposed of. So this is important in registration area. Second is in waiting hall. Some area we have similar names. Like in our area in Karnataka, Basavaraj is very common because Basavanna was born in Karnataka. So in Andhra, if you go Reddy, in Tamil Nadu, if you go Murugan, Senthil. So common names are very difficult. If you have 2-3 patients of similar name, then you may mistake the one patient to the other name. So what we should do is, usually what I do, what I have learned over mistakes is, we usually add the name of the place. like name and name of the place. So then it will solve most of the problems. And sometimes putting a dilating drops in other patient or attendant sometimes, because they are sitting together, both are giving a same face. So what we do is, whenever we put a dilating drop, identify the patient and give a cotton swab or a wipe, so that you can identify which patient you are putting a drops. And this is one of the areas where communication goof-ups can happen, is assumption. Majority of the times we Indians, we think if you go personal, the patient will be very happy. So if a patient of 30-year-old male come with a 25-year-old female, they come, sometimes we assume that they are husband and wife. So I have faced a lot of problem with this. So once one patient came, she had come with a headache. Then I thought they will be very happy with my joke. I told, this person is responsible for a headache, your husband. Actually, he was her neighbor. So that is you should never assume what is the relation between those who have come. So this is very important, because we Indians, we think that because I am married, because our generation we used to marry 3 to 5 years younger. So nowadays it is different. So we always think in that line. And assuming patients know the procedure. Now we know cornea is front, lens is behind, retina is behind, because we have read anatomy and physiology, pathology. Many a times we think that patient also knows what we know. Actually, for patient, retina is somewhere, cornea is somewhere, lens is somewhere. They don't understand the 3D concept at all. So thinking that patient knows, we explain the procedure. So this is one thing. So assuming that staff knows this. Some basics, when the patient comes inside, so patient has bought your time, so you have to be completely responsible and give 100% to your patient. Looking at the WhatsApp, answering the friends' calls, definitely they are not done when you are in with patients. So don't interrupt, let the patient tell his own story. If the communication is good, it is said 90% is listening and 10% is speaking. And no negative remarks on professional colleagues, it's understood. And stress the importance of follow-up, especially diabetic retinopathy and glaucoma. That's why I write, and we always have a reminder call for these patients. Even if you write, come after 6 months, they will come only after vitreous hemorrhage. This is very common with diabetic retinopathy patients. And one of the areas where is counseling room problems. Like, see, this clarity on charges. Just last week only, one patient told her, I told to put 40,000 rupees lens, you have charged total 40,000 rupees. The lens is only 20,000. So patient should know the split charges, what is the package charge, whether inclusions and exclusions. So you have to be very clear, that counselor should be very clear on the package charges. And 2-3 years back, one patient, I told you need both eye surgery. Then he came for the other eye surgery next day. Then he was very happy getting the surgery done. And next day when our receptionist asked told yesterday I paid for the both eyes. He thought the money was for both eyes. So you have to be very clear, the charges are for single eye. And very common problem is near vision problem after cataract surgery. If you don't counsel them that there will be a near vision problem after monofocal lenses, once around 4 or 5 years back I had operated on a patient. He was one-eyed. His name was Subhash Chandra Bose. Next day when I came, he was sitting like this. Then what happened, sir, I was reading earlier, now you have removed all my near vision. So you have removed my vision. So this is the problem. So unless you explain the near vision problem after monofocal lens surgery. And free from glasses or less dependency in glasses, this is also to be told. And flashy statements like throwaway glasses should be avoided. Always over deliver and under promise. And misinterpretations, many people think cataract surgery, phaco and laser are same, so you have to tell them. And Indian and imported lenses, better to avoid these words, better to tell premium lenses, regular lenses or type of lenses rather than using Indian and imported. Especially after this Make in India and Vishwaguru concepts, many people are offended if you say Indian lenses are less this thing than imported lenses. And laser is answer for all the ailment. Many people think like that. Avoid over sophistication. use simple words, think patient is a layman, and use in a very simple language instead of using vision, 6/6, contrast, color, all those multifocal, glare, halos. Better to be in a very simple language to tell the layman. And it's very difficult to tackle these Google graduates, tackle them in their own way. And too much weightage on IOL should be avoided. Take your responsibility and take your surgical skill into confidence. The take-home message is you have to prioritize the problem and who needs what, and tackle the complaint and treat the patient as a whole, not just the complaint. Thank you.
Good timing, sir.
Can we have Dr. Krishna Prasad's slides? Thank you so much, Dr. Ravindranath. I think the patient has come to the OPD and is agreed for cataract surgery.